Finals SAQ7 Guillain-Barré syndrome. A. What is Guillain-Barré syndrome and what are its causes? 3 marks. Guillain-Barré syndrome is an acute, immune-mediated, pre-junctional ascending demyelinating polyneuropathy affecting sensory, motor, and autonomic nerves. It is associated with respiratory or GI infection, especially Campylobacter, in preceding weeks. It is autoimmune in nature, with antibodies attacking the myelin sheath or axon itself. B. What are the clinical features of Guillain-Barré syndrome? 6 marks. Whenever we are describing a neurological condition, be clear whether it is upper or motor neuron lesion, affects motor, sensory, or autonomic nerves, and whether the defect is of axon, myelin sheath, or neuromuscular junction. Guillain-Barré syndrome has variable presentation depending on the subtype. Different forms are associated with immune attack or different parts of the neuron. Recovery is variable, ranging from full recovery to relapsing remitting form. Motor features: typically ascending symmetrical weakness, which is a flaccid areflexic paralysis. Weakness may ascend to involve respiratory muscles, leading to respi failure. Guillain-Barré syndrome may cause facial nerve palsies with bulbar weakness and ophthalmoplegia. Sensory features includes ascending sensory impairment associated with pain. Autonomic features includes arrhythmias, labile BP, urinary retention, paralytic ileus, hyperhidrosis, and sudden death. Miller-Fisher syndrome is a variant typified by ataxia, areflexia, and ophthalmoplegia with or without weakness. C. List the investigations with their findings that may be used to support the diagnosis. 2 marks. Blood tests. The following are variable, not specific or sensitive: hyponatremia, renal dysfunction, increased ALT, GGT, or CK, increased ESR with or without CRP. Antiganglioside antibodies are positive in 25%. These are antibodies against a certain component of the axon itself. There is increased association with Campylobacter. Positive antiganglioside antibodies indicate a worse prognosis. Serology may be positive for Campylobacter, CMV, EBV, HSV, or Mycoplasma pneumoniae. ABG may show respiratory failure. Stool may be positive for Campylobacter and other GI infections. CT brain to exclude other causes. CT brain is typically normal in GBS. MRI spine shows selective anterior spinal nerve root enhancement with gadolinium. CSF analysis via lumbar puncture shows normal cell count and glucose with high protein levels. However, protein levels may be normal early in the disease. Nerve conduction studies depends on the subtype. Majority shows demyelinating pattern. Some show axonal loss. Respiratory function tests show reduced vital capacity. D. What are the specific considerations when anaesthetising a patient recovering from GBS? 9 marks. Airway. Features includes bulbar weakness, poor cough, increased risk of aspiration. Intubation is required. Consider need for RSI. The patient may still have a tracheostomy in situ if still requiring ventilatory support or assistance with secretion clearance. Respiratory. There is increased risk of pneumonia secondary to aspiration and poor ventilatory function. Full assessment includes history, nature of secretions, temperature and chest auscultation. Treat as required and delay non-urgent surgery if necessary. Reduced ventilatory capacity may require non-invasive or invasive ventilation post-operatively. Cardiovascular. There may be autonomic instability with labile BP. There is sensitivity to commonly used vasoactive drugs. There is risk of arrhythmias. Invasive monitoring is indicated. Ideally include cardiac output monitoring to guide fluid administration. Ensure euvolemia as dehydration will exacerbate lability of blood pressure. Venous or arterial access may be tricky due to prolonged illness and multiple cannulations. Neurological. Neuropathic pain is common. The patient may already be on anti-neuropathic drugs with or without opioid analgesia. There is a need to plan post-operative pain relief. Involve the acute pain team. Pharmacology. Saxametonium is contraindicated due to risk of hyperkalemia following development of extrajunctional nicotinic receptors. Patients with GBS are highly sensitive to non-depolarizing neuromuscular blockers, hence reduce the dose. There is increased opioid sensitivity resulting in respiratory depressant effects, which may exacerbate the pre-existing respiratory compromise. The patient may already be taking opioids, hence dose adjustments may be necessary. Hematology. There is risk of deep vein thrombosis due to prolonged immobility. Continue thromboembolic deterrent stockings, pneumatic compression devices, and consider continuing pharmacological prophylaxis. Cutaneomusculoskeletal. Prolonged illness results in weight loss. Care with positioning and padding is required. Check renal function. Renal impairment dictates drug choices.